guess, doing all Zoom classes. It's quite the time. All right.
And different for sure.
I think I made you the host, so you should be able to share your screen now.
Sounds good. Let's share PowerPoint. All right, so you guys probably see like the full PowerPoint now, is that right? Not like presentation mode. Let's see. Is that showing presentation mode now, or?
Yes, it is.
Okay, great. All right, so that's my name, that's the date. All right, so just like a little bit of an overview. So I grew up in small town in Minnesota, about an hour west of Minneapolis. And I finished high school and attended undergrad at University of Minnesota. So the picture on the right there is the sculpture garden in Minneapolis and kind of the Minneapolis skyline. And you know, when I was in college, when I first went to college, honestly, I didn't know exactly where my career path was headed, but I was very interested in the law, though I was always interested in biology. So I double majored in political science and genetic cell biology. And while I was in college, I was fortunate to kind of get a job working in a research lab studying leukemia development and white blood cell kind of stem cell development. And so that taught me a lot about research. And as I was going through that, and I took a couple law school classes and did a little bit of shadowing in my junior year. Not shadowing, but I did like an internship with the Minnesota Attorney General's office. And, you know, I kind of discovered at that time that I think I had a very idealistic vision of what law could be, and that you could kind of dig into the law, find the argument, and then whoever makes the best argument, you know, kind of wins the day. But in reality, law can be a lot more complex, and there can be a lot more gray area, and you can kind of find arguments to back up whatever you want. And I discovered that that didn't necessarily kind of jive with my more logical mindset. And so then I kind of reconsidered things a little bit. And I had been working in this research lab studying genetics and such, and talked to my boss. And my boss had been, my lab principal investigator, my PI. And he had done medical school. He was an MD, PhD. So he had done kind of all through the whole system. And I had never really considered being a doctor, actually, being an MD. I didn't really think anything of it. I didn't have any physicians in my family. In fact, I was the first one in my family to go to college. And I always hated blood. And I was like, I don't see how I could possibly be a doctor. I didn't have a huge interest in it. But then he got me thinking about it a little bit. And I took a physiology class, and I discovered, I really truly discovered in the physiology class, like all the things you can understand about the human body and about medicine that I had no idea could be, understood in that way from studying and learning it. And then I also shadowed an oncologist in the community there, and kind of saw how much of an impact you can have by like understanding the subject and being able to, I kind of found that it was, a very concrete skill that you can bring and kind of really truly impact people's lives. So I decided to try to go to medical school, and took my MCAT during 4th year of medical school, and worked as a lab technician in that same lab for a year while I was applying for medical school. In addition, because I had studied political science and kind of always had this interest in equality of opportunity and justice, and kind of helping other people have similar opportunities as me to like, I've always felt so like blessed and lucky that I was born in the United States, where even though my parents didn't go to college and I grew up in this small town, I was able to get a world-class education and kind of have opportunities that many other places in the world don't have. That I did a little bit of volunteering. So for like 4 months right after I finished college, I went to Tanzania and just did some volunteering, which, probably in retrospect was not in any way kind of beneficial to the community in Tanzania or provided anything, of any significance there. But it certainly, I think I made some relationships, and I learned a lot about how complicated international development and things can be. And again, as I was going through that, it kind of really dawned on me how, for me, how kind of having a concrete skill like being a doctor could be so helpful, because even though many of these issues in international development are extremely complex and have lots of unintended consequences, etc., at least with concrete skills of a physician, you're able to make a concrete impact on people's lives. So with that in mind, then I was, kind of went back, finished up my lab work, and applied to medical school. And I attended medical school at WashU in St. Louis. And while I was there, I was interested, I had learned a little bit of Spanish during in that year after undergrad. And I saw it as a valuable skill, like becoming a physician this day and age. I thought that it was something that I really felt like I needed. But I certainly needed to develop it further. So we had kind of the summer off between first and second year of medical school, and I was interested in working somewhere where I could practice more Spanish skills. And I was lucky to find, at WashU, I found a group that was working in some research in Peru, and I was able to go work there for the summer. And while I was there, I was introduced to the group there who, in Lima, Peru, a group that works with the main kind of research university in Lima, and they collaborate with Johns Hopkins University. And so these two people, the two guys shown here are Bob Gilman and Will Checkley. They became my research mentors from Johns Hopkins. And I was very fortunate that I happened to be working there and working in the same, like they collaborated with the guy that I worked with from WashU. And it turned out, I didn't know anything about this. I'd never even heard of it. I had no idea. But it turns out that they actually work with a program that actually doesn't exist anymore, though there is a similar program now, that for medical students or people who are pursuing a PhD, you apply and can go and live and work abroad for a year in a developing country doing some kind of biomedical research. So I ended up working with them in Peru for a year, so between my third and fourth year of medical school. And I actually lived in Puno, Peru, so I'm sure some people on this call have either heard about people going to Peru, or some of you probably have been to Peru. But Puno, Peru is actually kind of right below the U here on the shores of Lake Titicaca. It's not that far from Cuzco, which is where Machu Picchu and all that is. So that's where I mostly worked. It was very rural. I had to speak Spanish all the time because there was like really nobody there speaking English, whereas a lot of other people did their research in Lima itself. And in Lima itself, there's, kind of a lot of expats and things you can kind of get around with a lot of English if you choose to. But I had an outstanding experience there. I did a lot of research on primarily studying how cook stoves, so people who cook in their home with wood and cow dung, how that affects heart disease specifically. So that's what we were working on, as well as kind of doing a little bit of side studies of high altitude diseases. So I did that for a year and kind of really solidified my interest in being able to at least be involved in some way, shape, or form in international research as part of my career. And I had a really good role model and really good example with Dr. Gilman and Dr. Checkley of this great program that they built, where they really helped train a lot of Peruvians in research techniques. Some of them went up to Johns Hopkins and got their PhD there and came back to Peru and kind of set up their own research labs there. And it's an extremely effective, sustainable model that I then kind of was interested in hoping to, kind of do something similar with my career. So after that, I finished medical school and I actually so I'm sure kind of through some of these others and just kind of through your own career explorations, a lot of you have discovered that becoming a doctor is no small task. In addition to getting accepted to medical school and actually not failing, you then have to go through many years of training. And so it's certainly something that when I talk to people who are thinking about medicine, it's definitely not a career path to take lightly. It's something that you really need to be pretty passionate about to get through, because you're talking, minimum after you finish medical school, you do three to up to like 7 or 8 years of residency training or fellowship training in whatever specialty you want to pursue. And in that time, you're taking on huge medical school debt in most cases, and then not really being able to pay it back at all while you're in residency. So whereas a lot of people who kind of come out of college and start earning an income at age 22, 23, you're really committing yourself to being in like negative, to be in a negative value, in like negative overall, I don't know, assets until you're at least age 30, essentially. And often even more if you kind of take some time off and do different things. So I did my internal medicine residency at Northwestern. So this is the beautiful shores of Lake Michigan in Chicago. And these are actually the Northwestern Hospital buildings right in downtown, right near the Magnificent Mile. It was an excellent time. I loved it there. It was 3 years. It was beautiful. The winters obviously are miserable, but I'm from Minnesota, so I'm used to it. It's fine. And after finishing that, I ended up then matching here at UNC to study oncology. And actually, the reason I ended up coming to UNC after, having lived all over the Midwest, not really ever knowing much of anything about North Carolina or about the Mid-Atlantic South, whatever you want to call it, was in fact that when I interviewed here, I discovered that UNC has a lot of projects working internationally in cancer in Malawi. So actually, as I decided, I really kind of fell in love with being an oncologist during my residency training at Chicago. I didn't know exactly what kind of doctor I wanted to be. I didn't know if I wanted to be more of a primary care doctor or if I wanted to specialize. I kind of went into residency very open-minded and wasn't really sure what path I would go on. In fact, if anything, I thought perhaps I would do cardiology because that's kind of what my research had been in previously. But as I saw patients and kind of learned what being an oncologist is like, that's when I really decided that was the path I wanted to take. I enjoyed that the science is very cutting edge, changing rapidly, a lot of options, a lot of different things happening scientifically that are very interesting and that are very beneficial for your patients. And furthermore, you also really get an opportunity to have a longitudinal relationship with your patients. And I think it's really rewarding. I find it really rewarding to be able to help explain kind of what cancer is, what it is in people's lives, and hear from them how it's affecting their life. And even, cancer can be really hard. A lot of people do die from their cancer. But it actually is really nice and really rewarding to be able to help people understand even what the dying process is like and help them kind of create the last, few months or years of their life that they would like. But knowing I took on that kind of role in cancer, I didn't really envision or know of a lot going on with international health, global health and cancer. So I didn't really think that there would be really a lot of options to integrate that into my career, at least early on, although I hoped, I went into thinking about fellowship, hoping that maybe after fellowship at some point I'd be able to kind of get back into that path. But I was fortunate that, in fact, kind of serendipitously, I interviewed at UNC. Didn't even know about their international program, to tell you the truth, until I showed up for my interview. And I found that they do, in fact, have a large program and are actually a very unique program when it comes to cancer working in Malawi. So UNC Project Malawi, for those of you who, some of you probably have heard about or maybe even have some experience working there at some point, is a collaboration between the University of North Carolina and the Malawi Ministry of Health. So actually directly with the government of Malawi. And it's actually been in existence since the early 1990s. It was initially focused around sexually transmitted infections and then kind of HIV throughout the late 1990s as HIV became a bigger problem in Africa. And that's primarily what most of the research has actually been in up until probably 2015. And then starting in 2015, it's really started to diversify a little bit because access to HIV medications has become quite widespread. And so now now there's quite a bit of research actually in kind of maternal child health, obstetrics, oncology, which is what we work on, as well as mental health, in addition to a lot of ongoing infectious disease research. So the mission, the mission of UNC Project Malawi is research. So they're trying to do a lot to kind of add knowledge, both globally as well as locally in Malawi, about implementing HIV treatment and implementing cancer treatments, et cetera, as well as kind of learning about HIV in ways that then can have broader impacts everywhere in the world. And then another kind of major component, there's certainly some clinical care component that we provide as we're working there, but the primary focus is really research and training. And so we do a lot of training, both to train providers, as well as to train future researchers. And so to the extent possible, we really help the people that we employ there, we really help try to provide them with additional opportunities to either get training in the United States or Europe or elsewhere in Africa or whatever they can get in Malawi to help them grow their careers. So when I interviewed, on the bottom right is Dr. Satish Gopal, who was my research mentor during fellowship. He actually recently got a job. He actually recently left UNC, and he was hired to be the head of the National Cancer Institute Center for Global Health. So it's like a pretty nice promotion for him. He's now in charge of essentially all the cancer global health across the entire National Institutes of Health. My research there was again funded by Fogarty, so it's called the Fogarty Fellowship, and then I had some research funding in other places. Finishing fellowship about a year ago, I was able to apply for, and I was successful in receiving kind of the first big grant that you get as an independent researcher when you're kind of on your own. So it's called, these letters and numbers don't need to mean anything to you for a long time. If you ever go into research, you'll learn about it. But what you get is kind of a career development award. So you get your own money to do research, but then you have mentors that are specifically also kind of paid to help you and kind of support you. And so that's kind of the first kind of major grant that I got. And so now I started as faculty as an assistant professor here at UNC. So with that in mind, many of you may have heard of this book already, or you may have had people recommend it to you, or et cetera, or you may not have. But I actually read this book just a year or two ago, and I definitely recommend it to everyone. It's by these two guys, Bill Burnett and Dave Evans, who are they're design engineers, and they are professors at Stanford, at least part-time professors at Stanford. I think one or both of them got their start primarily working in Silicon Valley, doing kind of design engineering type stuff, where they have some product that they want to design, and it's their job to kind of come up with a method of thinking through all the different ways that you might be able to design this thing and make it work for people and make it the most user efficient, etc. And they decided to take those design principles, so the things that are taught for design engineers for how to make these wonderful products, and to apply them to kind of how to plan out your life. And they took that and they made a course at Stanford that they teach that is, like, from what I understand, the most popular course that you can possibly take at Stanford University as an undergrad. And then as that course was so popular, then they decided to write a book that basically mirrors the course. So it's really nice. They talk a lot about thinking through kind of what you value, how you want to spend your time, what things you enjoy doing with your time, and when you're in a work situation. And then the biggest thing that I took away from this book that I think is really nice, and I recommend to everyone as you're out searching for careers or thinking about what you might want to pursue, is to go through the exercises that they give in the book that help highlight, what the things are you like spending your time doing. And instead of just necessarily looking around and trying to find a job or find a career that matches what you want to do, kind of flip the script and instead think about, if you could design the perfect job, what would you want it to be? And then go out and make that job exist. Go out, and when you start interviewing places or whatever, you tell them, like, this is what I'm looking for. Are you able to provide that? Now, for certain jobs, when you're just starting, that might not be possible, right? You might need to just kind of take what you can get, and it might be a very specific thing that they need. But as you get a little bit more kind of advanced in your career, I think it's a really nice message. And it's what I did when I was looking for my first jobs out of fellowship. I really thought about, how am I going to be spending my time, and what do I want that job to look like? So with that in mind, I thought it might be helpful for you guys to get an idea of how I spend my time and what I do every day now that I am an assistant professor and a doctor here at UNC. So like I said, my job's a little bit unique because I'm actually, now that I have this big research grant, it's not a big research grant, but it's enough that it gives me an opportunity to grow my research career. My primary focus is actually research. And so I probably spend 50 to 60% of my time just doing kind of research projects, running a research team, writing manuscripts, analyzing data, that kind of stuff, writing grants, that kind of stuff. And the other maybe 30, 40% of my time, another 30, 40% of my time, I see patients. So my job is set up, and again, this is like one of those things that as you get into it, there are many different models, and it depends on where you get a job and what kind of hospital you work in and how things are set up, etc. But I do all of my work as an inpatient doctor. So I generally only see patients in the hospital. I do see a few patients as clinic patients here at UNC right now because I am not able to travel to Malawi with coronavirus until probably the new year. And then certainly in Malawi, I also see patients. So in Malawi, I see patients like 2 days a week. And then if there are consults in the hospital, I go see patients in the hospital as well. And then throughout kind of integrating across all of that, there is teaching involved. So I teach and mentor researchers, people who are interested in doing similar research to what I do. I help try to kind of advance people's careers and help them do that, though I'm certainly very early on in that right now. But it is certainly something that I hope to do more of. And then likewise, as a clinician working in the hospital, I do a lot of teaching. I love teaching the med students and the residents about what we do and about, being a good internal medicine doctor as well as a good oncologist. And then we have kind of some nurse practitioners and physician's assistants who function, relatively independently, but I oversee them, and they are very often very specialized in cancer. And so I help teach them a lot more about kind of general internal medicine, general kind of patient care stuff. So I don't do a lot of classroom teaching per se. I don't teach in the medical school classrooms except for a little bit of the small group hematology session that I help with. So that's an overview of kind of my career trajectory and where I'm at now. I think I have 2 slides just like very briefly about a little bit, just gonna give you guys a little bit of an overview of HIV and cancer and kind of a little bit about, not even really go into the details of what I research, but just to kind of help you guys understand why I think it's important and why I think it's interesting. So this is just showing, this is some data published over time. As you can see in the top panel here, starting in like the mid 80s, they started to identify, that's when kind of HIV was identified. And people started, you can see most of the patients were relatively young at the time. And a lot of those patients at that time died of AIDS. There weren't any drugs for HIV until about 1993, 1994. And if nobody has seen the movie The Dallas Buyers Club, I highly recommend it. It is really interesting. It's about kind of when the HIV medicine started first coming out and what people were doing to get access to them. But then antiretroviral medicine started to come out and they started to have better and better medications. And as you can see, the number of people with AIDS has continued to grow, largely not so much because more and more people are getting infected, though that's not, I'm not showing that here, but in general, obviously some people are still getting infected over time, although that has come down significantly. But the biggest thing is that people are living longer and longer. One of the reasons people are living longer and longer is that we've learned better how to help, in addition to treating their HIV, we've learned how to treat the complications of HIV. And one thing not a lot of people realize is that actually one of the primary complications of HIV that people were dying from, and people still do die from, though certainly a lot less commonly, is cancer. So on the bottom panel there, you can see that over time, the number of cases of cancer among people with HIV has gone down significantly, especially across the mid-1990s. And this reflects exactly like when I told you, right, that the antiretroviral therapy started to happen around 93, 94. As soon as people started really getting access to that, the amount of cancer started to go down. And especially what we call AIDS-defining cancers, which I'll talk about in a second. And then over time, and this has continued, this has continued after 2005, the number of what we consider AIDS-defining cancers has continued to decline, and the number of non-AIDS defining cancers has gone up in these patients simply because they're living longer and they're getting kind of the same cancers that anybody else would get when they're old. So interestingly, a lot of the main things that you see, the main kinds of cancers that you see in patients with HIV are in fact cancers that are associated with an additional virus. So it's kind of, and it makes sense. If your immune system's not working well, the other virus that can then cause cancer is able to kind of run rampant. So what you're seeing here are what I want to kind of highlight are just that the 3 main AIDS-defining cancers are one type of lymphoma, which is caused by Epstein-Barr virus, Epstein-Barr virus is the same virus that causes mono. And what happens with these herpes viruses like Epstein-Barr virus and the next one, Kaposi sarcoma virus, is that you get infected with them at some point when you're young, and then you just live with that virus inside of you forever. And in most people, it never causes a problem. It never comes back. It never does anything to you. But if your immune system's not working, if you have HIV or if you have AIDS, then it can kind of come back and it can send your cancer fighting cells, which are the lymph nodes, in haywire, and you can develop lymphoma. So the three primary cancers, what we consider the AIDS-defining cancers, are lymphoma, like I said, associated with Epstein-Barr virus, something called Kaposi sarcoma, which is a skin cancer caused by the Kaposi sarcoma virus, and then cervical cancer, which I think many people are familiar, is caused by HPV. And then the non-AIDS defining cancers, and you can see here that, for example, Kaposi sarcoma is incredibly rare if you don't have HIV. It almost only happens in people with HIV. And as you can see, the problem is that even after people are on antiretroviral therapy, they still have an increased risk compared to the general population. So that's why that number there is showing, Kaposi sarcoma is 500, even with antiretroviral therapy, it's 500 times more common amongst people with HIV. Likewise, lymphoma is still 10 times more common even after people are taking their antiretroviral therapy. When they aren't on antiretroviral therapy, the risk is over 100 times the general population. And then there's some that are what are considered non-AIDS defining cancers, but are again still much more common amongst people with HIV than amongst people not with HIV. So lung cancer, and this may just be because it's a much higher smoking risk among these patients as well, or smoking rate. Anal cancer, because that's also caused by HPV. Although hopefully, hopefully anal cancer and cervical cancer will go down and down as we get more and more HPV vaccine out. Hodgkin lymphoma is also 8 times more common even when you're taking your antiretroviral therapy. Mouth cancer, also caused by HPV. Hepatocellular carcinoma is caused by other viruses, hepatitis B and hepatitis C. And then these vulvar cancer, penile cancers are also caused by HPV. So, given all that information and how it, despite the fact that people are getting antiretroviral therapy, cancer is still a major cause of death for these patients. We feel that studying this, so there's kind of 2 parts of my research that I do in Malawi. One of them is just kind of studying the underlying characteristics of patients with HIV and cancer in Malawi, and trying to learn something scientific about the immune system and how it interacts with HIV and cancer. And then the other side is mostly just focused on what are the ways that we can implement cancer care in an extremely low resource setting. The GDP per capita of Malawi is still less than $1 per day. It's an extremely poor country. And so trying to find ways to, especially for curable cancers like lymphoma, where if you cure them, people can live a normal life the rest of their life, finding ways to safely and effectively implement that in a cost-effective manner is the other thing that we're trying to do. So that's all I have. That's my email. Anybody can reach out. I think I spoke longer than I planned to, but I am happy to take any questions.
Yeah, thank you so much for sharing your experience and research with us. We can go ahead and transition to the Q&A. Our first question is, where do you hope to end up in your career, like career goal-wise?
Yeah, I mean, I think right now I'm at a pretty good place, kind of just starting my academic career. And my goal kind of going forward from now is that I hope to continue in this research path. I hope to kind of learn some things during these next few years and then apply for larger grants that will allow me to have kind of bigger research teams and kind of pursue additional research questions. And then along those lines, as I'm doing that, I hope to continue to kind of train the next generation, right? So to find future PhD students, future doctors and residents who are interested in this subject to kind of train with us, both people from the United States as well as especially people living and working in Malawi, who are from Malawi, who are going to continue to live and work there, with the goal that it's easier for me to, I think about the kind of goal for the program than like my own specific career path, but with the goal then that the program can become self-sustaining, that those people who we mentor and who kind of work under me then able to get their own grants and their own funding and kind of build their own research career. Yeah, so it's mostly about that. It's kind of about, in addition to some certain scientific kind of questions, like I said, about HIV and cancer in the immune system, also about really kind of trying to, to kind of build and improve the health system in a way that can be sustainable and kind of benefit the care of cancer patients in Malawi. I know, I'm very aware of the fact that a lot of programs that are done, a lot of things that are done in service of trying to improve health systems and et cetera in low-income countries can often backfire and have unintended consequences. And kind of trying to stay aware of that and do things in a way that I think are sustainable and in the in the desire and wishes of the country in which we're working. Yeah.
Awesome. Thank you so much. Our next question is, did you do anything else after being in Peru to work on your medical Spanish? Are you fluent now, and how much do you use Spanish in your career today?
Yeah. So after spending those few months there, then I did go back for a whole year. And so by the time I was there for a whole year plus, by the time I left there, I was fluent. So I am fluent now, and at different points in my career, kind of depending on what kind of patients I'm seeing and what service I'm on, I have a varying level of number of Spanish-speaking patients that I see. I will say it's not like a game changer. I think it's not the biggest deal in the world. There's great access here at UNC to interpreters. But for me, it's just such a huge benefit that I'm able to talk directly to my patients without an interpreter. And not only do I feel like I can connect a lot better with them. For example, when I speak with my patients in Malawi, many times, most of those patients speak Chichewa, which I don't speak. And I find it's really hard to feel that same like humanity, that same connection to my patients that I can hear speaking in either English or Spanish. And then the other major advantage, I think, it's just like so much easier for me day to day to just, I probably see maybe like two patients a day when I'm in the hospital that are Spanish speaking, but I never have to worry about the logistics of calling the interpreter, waiting for them to show up, interpreting through them, et cetera, et cetera. I'm able, and same thing with my team that I'm rounding with the rest of my team. They don't have to call the interpreter because like we can just go in together and I can just interpret for everyone. So it's a lot of advantages, both like personal connection to make kind of what I'm doing day to day more rewarding, as well as just like making my job more efficient.
Thank you for that. Our next
Mm-hmm.
question is, what do cancer treatment options look like in a resource-limited setting like Malawi?
Yeah. So right now, in general, we have access there to kind of basic chemotherapy, which are chemotherapies that have been around in the US probably more than 20 years now, for the most part, or longer. But one of the things that we're interested in is actually this idea of almost that we are constantly trying to find ways to study, is what I would call like a leapfrog, kind of leapfrog advancements. So instead of necessarily thinking about how do we take exactly where people are in Malawi now and getting them up to the level of like treatments that we have here in the US, instead thinking about what are some places where actually we can actually make advances in Malawi that aren't even available in the US yet, because it might actually be better for patients in Malawi where there are certain unique characteristics of the treatment environment that make it better. So a concrete example I can give of that is that maybe in some of your classes you guys have had, because it's been such a game changer across many cancers, is immunotherapy. And immunotherapy kind of helps release the immune system to fight cancer. And there's a lot of parallels between those medications and actually what happens when you start to treat someone's HIV. And so one, there's some interesting science questions that we can learn from the HIV and how that relates to these immunotherapies. But two, it's actually a lot more dangerous in Malawi to give people high dose chemotherapy because they just don't, people live far away. It's not great access to medical centers. There are only 2 medical centers in the whole country that actually give chemotherapy cancer treatment. So it's hard for people to get back quickly. And there's not as much access of like immune boosting medications. Like we use GCSF to make the immune system come back. We don't often have access to that. So some of these high intensity treatments that you need to cure people are actually much more dangerous in Malawi. So if we could, instead of just trying to like get people up to like the right intensity of chemotherapy, perhaps we can use medications that have fewer side effects, that are safer to give, and we can kind of even just like kind of leapfrog straight ahead. So with immune therapy, for example, in Hodgkin lymphoma, one thing we're interested in doing is essentially creating a chemo-free treatment, which has been tried in some advanced cancers here in the US, but it's actually never been tried in kind of first stage Hodgkin lymphoma. But there's reason to believe that it would actually be a better treatment, a more effective treatment in Malawi, where there's more side effects from regular chemo for people there. So we could kind of even leapfrog ahead of what they're doing in the United States. And it would be something that then anywhere in the world, they might learn from that and say, oh, maybe we should be doing that here too. So.
Very cool. Thank you. Our next question is, why did you choose hematology over other specialties?
Yeah, I think it relates to some of what I talked about in my, what I was talking about, that I kind of discovered that I really liked it during residency. I had been, I'd had some exposure to it during undergrad because the lab that I worked in was all about hematology. And then, yeah, it's really more kind of, I had a little bit of exposure during undergrad, and so I had some familiarity with it. And then, as I mentioned, during, going into medical school, I didn't know what specialty I wanted to do. But as I went through my rotations in medical school, I certainly found that I was internal medicine was definitely my kind of way of thinking. It's like a very cerebral specialty. It's not there are procedures that you do, and depending on what part of internal medicine you go into, you can do more or less procedures, but it's not like surgery where you're in the operating room all the time. It's a lot more about using medicines and thinking through what might be going on, etc. So I definitely knew I wanted to do that. But then after, during residency, it wasn't so straightforward kind of if I wanted to subspecialize or what type of subspecialty I wanted to do. And yeah, like I said, I really liked the interactions with my cancer patients in residency, and I realized that if I wanted to do more of a research-based career, which is what I wasn't always sure about that, but I kind of I fell into that eventually because I felt like I wanted to do something a little bit bigger than only seeing patients directly. And there are a lot of ways to do something bigger. I mean, I think teaching in a residency program is a great way. Administration is a great way. There's a number of ways to do that, but for me, research was the path I chose. And I felt that in order to really be successful in research, I needed to subspecialize. And so that's where I kind of fell into hematology.
Thank you for that. Our next question is, when it's normal, how much of the year do you spend in Malawi?
Yeah, so up to now, it's been a little bit weird. So I did a year during fellowship there. And then I went back, and then I was back and forth a bit for kind of the last 2 years or so. I was did like 3 months a year there as I was finishing up my training. And then now the plan is to I probably spend at least 9 months a year there and kind of 3 months here. That has been delayed because of coronavirus, but the plan is for the next probably 5 years or so, I'm planning to spend the majority of my time there.
Thank you so much. The next question is, hold on, sorry, I lost it. So the person said, I'm interested in health economics research as well. Do you have any formal training in economic evaluations? And is it necessary to have a PhD in health/econ or health econ/health policy to do that type of research as a physician?
Yeah, so certainly not 100% necessary. There are a lot of ways to get into research as a physician. I I certainly value more and more, or I see more and more my deficiencies at times, and I definitely understand and realize that I'm not going. I don't see myself becoming necessarily like a methodologic expert in health economics and that kind of thing going forward. But I do know enough to do the very specific projects that I'm interested in. And I've been as part of this. So one of the nice things is if you do get into this kind of career development award, like what I'm doing, it provides protected time to do additional training in something that you're interested in. And so for me, for example, I am taking a couple of classes. So I'm taking like the intro to data science class that's offered through the School of Public Health right now, which is teaching me a little bit more about how to manage data, how to, make things more reproducible. I took a course that's offered through this group in Toronto at like the Sick Kids Hospital in Toronto. That's specifically an R analysis course for data analytics in health economics. And so they have like, kind of specific R templates that they teach you about and that they give to you that you can then kind of plug your data into to do very specific economic analyses. But there's no doubt as I go forward, if I want to do any huge, significant, big parts of economic analysis, I will have to work with a PhD. Yeah, I will not be able to do a lot of it myself.
Thank you for that. Our next question is internal medicine most conducive to research careers?
I wouldn't say that. I think any specialty can be conducive to a research career. In fact, like you would think maybe surgery is one of the least conducive to research, but I don't think that's necessarily true because in fact, during residency, a surgery residency sets aside, there are a couple different kinds of surgery residency, but if you're interested in research, general surgery programs actually give you 2 years of dedicated research time during your residency. So I think I wouldn't say that. I think you can do research in any specialty.
Awesome, thanks. Our next question is, could you talk more about the patient-facing side of working in an oncology and like your experience with that?
Sure. I don't know. It's a little bit non-specific. Yeah, I don't know. I don't really know how to answer that. Yeah, I mean,
Sorry, that was my dog. He's going crazy in the back.
Yeah, I see. Yeah, I mean, I think there's a lot. So most patient care happens in a clinic. So most people see their patients in clinics, and it's kind of like what you would expect. You kind of see your cancer patients, and then in the clinic, talk to them, have some time to talk to them, and then maybe they'll go get their chemotherapy treatment, and you'll see them back in a few months. It's kind of your typical whatever kind of clinic experience, and then unfortunately, patients do get hospitalized even when they're first diagnosed with cancer or when they have some kind of complication or etc. And I actually generally see patients in the hospital, and so it's a little bit less when you're seeing mostly hospitalized patients. It's a little bit less of that. Well, a lot less of that kind of long-term relationship with your patients. But it is, I don't know. I mean, I still really like it. I still find it really challenging. A lot going on every day. I mean, I'm on service in the hospital right now, and I'm like running around like crazy. And there are still rewarding moments, like really helping people. We've had a couple of patients this week who have had new diagnoses of cancer, so it was my job to help teach them about cancer, what it means, what the treatments will look like, what the chances are that they'll be cured, that kind of thing. And then we've had a couple of patients who actually, frankly, are dying from their cancer, and we don't have any really good way to change that. And so it's really working with the families to help them understand that that's what's going on, and really deal. It's really, I honestly just like love being a doctor because you get to really experience like the full spectrum of society. People come in and they have everything from people who are rich and they like want their own private room or private whatever, like some fancy things, very demanding, or there are people who are, you know, in extreme poverty, and you get to also hear the story of their life and how they ended up where they are, and how their cancer is affecting them. And you have to also, you know all those things and deal with all those things, because it impacts their treatment. It impacts, you know, how you can deliver their cancer therapy. So yeah, so we've had a few patients who, like I said, you know, they've been dying, and so you have to deal with the unique circumstances of their family and how they experience cancer for themselves, and how they, you know, how they envision the, you know, kind of the end of their lives being. And, you know, whether that's in the hospital, dying in the hospital, and trying to do everything they can to save them because they, you know, whatever reason that they feel like that's what's best for them, or other people who really don't want to be in the hospital and they just want to have time at home with their family. And yeah, it's really rewarding to be able to, it's really rewarding, and it's really special to be able to have people, I mean, as a doctor, people will share all their secrets with you, and it's really nice to have that, you know, to feel trusted like that.
Thank you for sharing that with us. Our next question is, what are some further research questions you hope to pursue in the future?
Sure. So we have a lot of things going on. We, as I said, my research mentor recently left, so we've kind of branched out into kind of smaller little groups now, doing little different things, but it also provides a lot of opportunity. We have kind of more people doing cancer research in Malawi. I think my own personal interests are around this kind of the two things that I mentioned, which are like the interaction of the immune system and HIV. There's actually this really random, super rare cancer. It's not truly a cancer, but you can think of it as a cancer called multicentric Castleman disease. And it's really unique because it, in fact, is also caused by that same Kaposi sarcoma herpes virus we talked about, but it tends to happen in people when they've actually been treated for their HIV for many years. Whereas kind of everything else usually happens, most other diseases and like HIV associated problems actually happen when people happen at higher rates when people are poorly controlled in HIV. This disease actually doesn't ever happen then, it happens like later on. And so we expect that, and it's that herpes virus, that KSHV, is also much more common in sub-Saharan Africa. So we actually expect that this type of cancer is going to become more and more common over time, because more and more people are getting access to antiretroviral therapy. So, but because it's incredibly rare in the United States and in Europe, there's very little actually known about it. And so there's actually a lot of interesting kind of basic science research and treatment research to be done on that disease that can have a major impact in sub-Saharan Africa.
Wow, thank you so much. Our next question is, does UNC offer opportunities abroad does UNC offer opportunities abroad to do only clinical work, or do you have to do research?
Yeah, there are opportunities to do clinical work, especially for medical students and pharmacy students. So the pharmacy school tries to have 2 students there at all times throughout the whole year, doing just clinical work for a month at a time. The medical school and medical residents, so medical students, some, but more kind of medical residents in different specialties, frequently rotate through doing clinical rotations abroad. Yeah.
Thank you for that. Our next question is, what would you say are the top spoken languages that would be good for a doctor to know?
Um, it's difficult. Well, definitely English, number one, because that's kind of the universal scientific language for whatever it is, what it is. And yeah, in addition, in the United States, I mean, you know, honestly, for the most part, at most hospitals and things, it's going to be very kind of unique to different communities, I would say. You know, certain areas of the country, there may be a lot of Mandarin speakers where Mandarin will be very useful. Maybe Seattle, San Francisco, something like that, where there are a lot of kind of Chinese immigrants. And a lot of, for example, like I lived in Minneapolis for a long time, and in Minneapolis we have a lot. Arabic is really useful. We have a lot of Somalians, and in addition, there's a lot of Thai kind of Laotians that live in the Minneapolis area, refugees. So speaking that language can be more helpful there. And then certainly, throughout the United States, I would say definitely Spanish is the second most important after English, universally across the U.S. But for the most part, those things can be helpful, and I do think certainly I think Spanish can be incredibly helpful for your career. I think it can make things a lot easier for you if you speak it yourself. That being said, there are also tens of thousands of native Spanish speakers in this country who can serve as interpreters, and so it's actually very incredibly easy to get interpreters kind of, I would say, probably at almost every single hospital in the United States, either on a phone or in person. So it's certainly not critical that you learn it yourself.
Thank you so much. I think we answered all the questions. So if anyone has any last minute questions that they'd like to ask, go ahead and put them in the chat. But I think we'll give them a couple minutes or a couple seconds to ask any last minute questions. Someone asked your favorite case you have seen. I'm not sure how much.
Oh my gosh.
Think about that.
I don't know. I don't know. I'm not sure. Yeah, sorry.
All right. Well, thank you so much for being here today. We really enjoyed hearing about all your experiences, and thank you so much for talking with us.
Yeah, thank you
Of
so much.
course. I hope it was helpful.
It was definitely helpful. Thank you so much.
Helpful.
Have a great rest of your day.
Thanks, everyone. Bye.